So this is a 31-year-old female. I saw her a couple weeks ago. She has a history of IV drug use. She first started about 12 years ago, and she's been clean for about 7 years. She does smoke cannabis daily. She vapes, and she has occasional alcohol, 1 to 2 drinks a month. She said it's usually wine. She has a history of anxiety. She has a normal exam. Her ultrasound showed fatty liver, no lesions. Elastography was F0. It's the wrong case, that's all. She is.
That's my case up there.
Is it really? I am so sorry.
I
What
just
is
caught that.
happening?
That's okay.
Oh my gosh, Elizabeth. What is happening? This is not the case. Sorry, my dogs are really loud. As well.
So we're seeing Jen's case on our end.
Let me stop share. That's so strange. I'm so sorry. Is it showing up now? No. Why is it different?
No, that's the right one.
Oh yeah,
This
we
one,
can see now.
it looks different on mine. It's so weird. Okay.
Her BMI is 28.2. Overall, her labs were good. Her platelets 233, ALT is 38, AST is 39. Her APRI was 0.4, child was 5A, MELD was 7. Iron's good, genotype 1A. Her serum fibrosis biomarker was F0. Her Hep B surface antigen and surface antibody were negative, but she does have a positive core. So basically, do I need to do any further testing, or what is the way to go from here?
I'm so sorry. Again, my apologies. If you guys need me to pull that case back up, please let me know. If not, does anybody have any clarifying questions about this case?
Hey Gary, this is Kaylee. Is she on any type of contraception?
No, in her drug, I did order a pregnancy test.
Gotcha.
I meant to say that earlier.
All right, anybody have any recommendations?
I guess I'll go. This is Kaylee. And I apologize because the background, they're doing some construction over here, so it might get noisy. Just tell me to repeat myself if you can't hear me. But your question about the Hep B core antibody. So there is a risk of reactivation, Hep B reactivation, regardless of which direct acting antiviral therapy that you choose. However, since this isn't an active Hep B infection, her Hep B surface antigen's negative, really there's not anything special you necessarily have to do other than monitor for reactivation. It's about a 2% risk. And so just make sure you're counseling the patient on signs and symptoms of clinical hepatitis. Let her know you'll be monitoring hepatic panel more frequently. I usually just check it with treatment week 4 labs. If those are increasing, then you can go ahead and repeat the surface antigen. You can check the Hep B DNA. But the risk of reactivation with an isolated core positive test is very low. It can happen, but pretty low. And then, you know, with her, since she's really not on any medications other than the Lexapro, you really could do either 8 weeks of Mavorite or 12 weeks of Epclusa or the generic Sofvel for 12 weeks. Either one would be fine. Just make sure, you know, she's certainly avoiding pregnancy. And if she starts on any contraception, just recall that drug interaction with ethinyl estradiol and Mavorite. So you'd want to avoid that while she's on treatment if you do choose that option.
I have a question along that line, if that's okay.
Of course, absolutely. That's what we're here for, Dr. Rexford.
Well, I was talking with a Hep C patient last week, um, and she is interested in potential treatment. She's 41 and trying to conceive. So, do we tell her to avoid that during the treatment? What's best on that?
That's a great question. Ideally, and I understand being 41, time is of the essence. So I'm sure she wants to, try sooner than later. But I mean, ideally, you'd want to get her treated before she's pregnant. Generally, in my patients who are trying to actively conceive, I let them know, your viremia is going to be negative pretty quickly, and pretty soon into treatment. Maverick's only 8 weeks, so if she can hold off for 2 months to get treated, that would be ideal. She doesn't even necessarily have to wait for SVR12 for that lab work to come back, because truly the treatment cure rates are so high that we assume, as long as they're taking the medication appropriately, that they're going to achieve cure. So she doesn't have to wait until SVR12, but I certainly would make the goal to treat prior to conception. Now, aside from that, again, it's really that no treatments are recommended with pregnancy at this time because the data isn't widely available. There's a small study with Harvoni in particular and pregnancy. It was only about 28 patients, I want to say. It was out of Pittsburgh, actually. And the patients still achieved SVR at the same rates as if they were not pregnant. There were seemingly no toxic side effects, to the fetus. But again, this is kind of early data. So if she's, really feels strongly about not waiting that 2 months to get her treated, just make sure she understands that data is not available. We just don't know. We don't know if it's going to be impactful. Probably will be okay. Probably won't have any negative effects to the baby, but we just don't know that. And then same thing with breastfeeding. We just don't have any data to support. We really recommend waiting for treatment until breastfeeding, she's finished with breastfeeding. But it's really more from lack of data and rather than like proven adverse effects.
Okay. Well, and I wondered too what treatment would do to her odds of getting pregnant. If we get rid of this chronic disease.
I don't know. That's a fair point. I truly don't know if there's any literature about that, but I understand the thought process behind it. The other thing too to think of is we see with pregnancy, although I probably wouldn't want to risk this, but vertical transmission's about 6% as long as they're HIV negative. There's a few other risk factors that can kind of increase that vertical transmission risk. But there's about a 10% likelihood of spontaneous clearance of Hep C viremia in the mother with each pregnancy. So, with those immunologic changes, there's that chance as well. I've had it happen a few times, and it wasn't on purpose. We weren't waiting for her to get pregnant to just see if she's going to clear the Hep C, but it turned out that we were going to start treatment. Found out patient was pregnant, said, hey, come back and see me after you've delivered. And then 2 years later, oh, by the way, Hep C testing is now negative. So that can happen too. I would really opt to treat before that. But, every case is different. So I think as long as you're counseling on the, risk that we just don't have that information available about adverse effects to the baby, then, she may choose to go ahead and do treatment while she's actively trying to get pregnant.
Thanks.
Very great questions. Thank you, Dr. Rexrod. And those are interesting results for sharing. Thank you, Kaylee. Gary, do you have any other questions before we go to Jennifer's case?
Oh, I'm good. Thank you.
Of course. Thank you so much for submitting that. Give me one moment. I'll make sure it's right.
It's good to know you make mistakes. Or that you've made one.
Of course. Of course. I just hide the rest.
That was a really interesting conversation about treatment and potentially childbearing people. Thank you. So my case today is a 34-year-old Caucasian male with Medicaid insurance. I saw him 2 or 3 weeks ago, and he was diagnosed in 2013, back in the days when treatment wasn't approved unless you were fibrosis stage 2. So he saw a gastroenterologist at that time and was told that, as he put it, there wasn't enough damage to my liver. So he was kind of lost to follow up and was seen by a provider in my practice here at New River. It's interesting, his LFTs were really high. As ALT was over 600 at that visit. And anyway, she followed up on the Hep C and referred him to me. He likely was infected through intravenous drug use, which he started in the year 2007. But he's been sober for 2 years and feels solid in his sobriety. He did get a non-professional tattoo a year ago. He is a smoker. At the time that I submitted the case, he was not on medications, but he since then has been started on Topamax. He has really pretty severe anxiety. He was really anxious and wanted me to prescribed medication for him at this visit, but he was scheduled with a psychiatric provider, so I encouraged him to see them then. And since then, she has prescribed Topamax. He does report occasional joint swelling and aching that he thinks is normal, but I told him all that might improve after treatment. He lives with his dad. His physical was normal, except for he was slightly overweight, and he does have those tattoos. One thing, just if you can back up a tiny bit, Elizabeth, so he was not immune to hepatitis A. He has had the entire Hep B series documented, but his surface antibody and core antibody were negative. And so one of my questions, I want to confirm that I should give him one booster dose of the hepatitis B. But so anyway, that we'll just remember for later. Those are his medications, Topamax and vitamin D. Okay, we can go to labs. Thank you. By the way, he did have an ultrasound ordered by his PCP, but he was unable to get it. And so I ordered elastography for him. So anyway, his BMI is slightly elevated, 28. His CBC was normal. You could scroll down. Creatinine, glucose was in the middle of the day. PT-INR were normal. On this day, when I repeated his labs, his ALT was down to 284. His AST was quite elevated, 410. And you can see his other liver enzyme results there. His APRI was 5, child Turco-Pugh class A, and MELD score was 6. His ferritin was 115. For some reason, either I didn't get or the lab didn't do other iron studies, but I figure that that's okay given his normal CBC and normal ferritin. If not, let me know. We started him on vitamin D replacement. His AFP was 2.5. He's not, he does not have HIV infection. His genotype is 1A, and his viral load was 10 million. I'm glad to know that that's the highest one I've ever seen. I'm glad to know that it doesn't necessarily reflect the severity of his disease. So when I saw that, I was impressed. And his blood work showed fibrosis stage F1 to 2. So I would treat this guy with probably Mavorite, as long as that's okay with Topamax. I know Epclusa would be another option. And I just as comments, I would say I would repeat, in addition to his Hep C titers, I would repeat his fibrosis marker and hope that that comes down if the transaminitis calms down. And he had an elevated GGT. I don't think I put that on here. It was like 115, and this is unusual. I failed to ask him about drinking, and I most certainly will. I don't know how that eluded me, but I have to follow up with him to have him sign the patient consent and let him know about his medication and such. So I'll definitely enforce that then, because usually I recommend that he not drink if he's drinking. So that's my story on this guy.
Thank you so much again, Jennifer. Does anybody have any questions before we go into the recommendations portion?
Hey, Jennifer, I had a question. It's John. I mean, Kaylee. Actually, it's John. Sorry. Do you know, did he actually seek care in 2013 from that gastroenterologist that told him no?
He saw him, and then I don't know. I can't remember.
So I'm gonna, yeah. So
jail.
Oh dear.
I can't remember.
The patient or the doctor?
The patient, not the doctor.
Oh, okay. Well, not that that's good, but it's relieving somehow.
Yeah.
So I'm going to shed a little insight into how the conversation that I have not any proof of this, but how I think it must have gone. So 2013 was before the direct acting antivirals. And so, so it's fascinating. We used to use, and the fact he got a liver biopsy and stuff like that, it's kind of cool. But so because the treatments were so lousy and we didn't have, they were very toxic and didn't have a great success rate, we really triaged people, hoping that things would be better in the future, which they eventually did get a lot better from a treatment perspective. But we would use the fibrosis score back then to see if you really needed it. We were like, man, are you getting in trouble from this? And so sometimes we didn't treat people, not because they weren't sick enough to warrant therapy like we did with the financial paradigm going forward after direct acting antivirals came out, with treating only the sickest people first. We sort of didn't want to treat you if maybe you were one of these people who was going to be able to smolder along until we were going to get better stuff, if that makes any sense. So we definitely had and I'm not sure that's how the conversation went, but I'm thinking that's how it went at the time. So remember, 2014, 15 is when, sofosbuvir and then some other wild ones came out. But gut feeling is he actually didn't get treated because the GI doctor didn't want to give him interferon and the protease inhibitors at the time. So.
I had forgotten that. I'm sure you've talked about that before, and it's sort of astonishing that, because 10 years ago is not that long, and really we've been doing echo since 2016. So it's really interesting to have that perspective on how quickly things changed and how much they changed for people.
Yeah.
If I knew that, I had completely forgotten it, but I think we talked about that before.
The only one of about 2 or 3 pleasures of getting older is that beautiful perspective that we can harken back to. Your thoughts of Mavorite and is a great idea from my end. I didn't run all the med lists, but I did run Topamax, and it doesn't seem to interact with Topamax. Kaylee, I don't know if you want to. I know you just did Hep B vaccination review and stuff like that. I don't know if you want to touch on that, how to revaccinate this guy, or you want me to wing it?
Yeah, sure. So if he has no evidence of response, so surface antibody 0, I would go ahead and revaccinate him. If you have access to Heplisav, the Hep B conjugate, I would recommend that one because it has higher response rates and for a longer duration. If he has like just a suboptimal titer, like it's 8 or 6, you could probably just give him a booster.
Okay.
And then that should kind of wake up his response.
Yeah, it was 3 or 3.1 or something. And I do remember you gave that fabulous didactic on all that, but I didn't look it up. So thanks for repeating that. So you think just a booster even with a titer of 3?
Sorry, I was muted. Yeah, I mean, if you have access to Heplisov, I try to get all the patients that have had kind of suboptimal response vaccinated with the Heplisov. But if I know that's pretty costly, just depending on if he has Medicaid, it should cover it. But it sometimes is not feasible to get access to that one. Some pharmacies will carry it too. You can just write the script and they should be able to order it. But otherwise, yeah, you can go ahead and just give him a Hep B booster. And then you could always just recheck his surface antibody in 2 months and make sure that it's kind of woke him up, his a response. If not, you could just repeat the whole series.
Yes. Okay. Thank you. That's it for me, Elizabeth.
I love that you're doing elastography on that guy. I'm a tad worried about his liver.
Yeah, I'm very curious to see what they had originally just ordered ultrasound, and so I switched it, and so that's good to hear that you approve. Thank you.
And definitely the drinking assessment's a good idea. He's got a couple things in there. Kaylee had pointed out to me when we were reviewing these cases, his AST being super high.
Yeah, I would tell you, Jen, I can very confidently tell you he drinks.
Okay.
I mean, and with his AST to ALT ratio being like 2 to 1, and then his GPT being high, he drinks.
Yeah. The poor guy, he's probably just self-medicating. He was so anxious when and by the end of the encounter, he was less anxious, but it made me angry. It's one of those words like, so.
Sure. I could understand that. I tell patients that drink, even if they don't admit to drinking a excessive amount, that any amount of alcohol is like pouring gasoline on a fire. So he's got to cut that out.
It's usually in my routine, and I think I might have been so rattled by his anxiety that I forgot to talk about it. Just how things go sometimes.
You're human. I've done that so many times, and then I'm like, oh my gosh, what of all the things, like how could I?
No, it's funny thinking back on it, but I feel certain PCP is probably told.
Listen, it happens. We're human. You have opportunities to revisit that with him, so don't worry. Don't worry.
Excellent job. Thank you so much. And plus, I think some of the medicine, like, is Tobamax okay to drink with? I'm not really sure. Rachel, or Angie. You could use that as a backup. Like, don't drink, and you're on this. I actually chose not to take certain medicines for my anxiety, so I could drink. So if that tells you anything about me. Anybody else have any questions or comments? All right, then I think we just have a final announcement, unless you guys have anything else you want to add or put in the chat or anything that you're not comfortable with sharing with the group. Kaylee will be next to discuss on July 27th, harm reduction in PWIDs. All right, thank you, everyone. Good to see you as always, and have a great rest of your week.
Thanks, everyone. Bye.
Bye.